Now we are going to look at spinal anesthesia, its indications, types, and all about spinal anesthesia. So indications of spinal anesthesia are surgeries of lower limb, pelvic, perineum, or if there is any renal procedures are going to happen, are cardiac diseases, liver disease, and obstetric anesthesia. We can use spinal anesthesia, or it can also be taken out in the immunocompromised patient who does not impair immunity, elderly patients, and diabetic mellitus. We can do spinal anesthesia because cutting the organ or skin can cause delayed wound healing in diabetes mellitus. So spinal anesthesia is very good choice. And contraindication of spinal anesthesia: patient is refusing if there is infection at the site, if there is increased intracranial pressure, or if there is any hypovolemia, drop in blood pressure, shock, hemorrhage, septicemia, severe aortic mitral regurgitation, coagulopathy. These are absolute contraindications in which we do not have to do spinal anesthesia at any cost. Relative contraindication is spinal cord problem, or any peripheral nerve disease, polio, multiple sclerosis, brain tumor, meningitis, uncontrolled hypertension, valvular disease, or any anticoagulopathy there. Relative contraindications are spinal anomalies and congenital anomalies, prior back surgeries and obstetric hernia, or any uncooperative or any abrasive patient. So these are some relative contraindications. Now, as we can see, the anatomy of spine is there are cervical, thoracic, lumbar, sacral, and coccygeal vertebrae, and we have to perform lumbar tape at the level of L3, L4, and we have to cross certain uh, structures for spinal anesthesia like skin, subcutaneous fat, supraspinous ligament, interspinous ligament, ligamentum flavum, epidural space, dura, and then subarachnoid space at L3, L4 level. So we have to insert the needle in such a way that it does not cause obstruction because of bones, spinous process of the vertebrae. So we have to take care of that thing by uh, technicalities. Spinal cord usually ends at L1 in adults and L3 in children. So we have to perform lumbar puncture at L3, L4 level, and dura puncture above these level associated with the risk of damaging of the spinal cord. To avoid that, we have to locate the top of iliac crest, which is known as Tuffer's line, L4, L5, and then we have to insert at L3, L4, a spinal needle at L3, L4. So in this way we can do successful spinal anesthesia. Now, as you can see, there is the first line which is at L4, L5, which is at the top of iliac crest, and we have to perform lumbar puncture at L3, L4, possibly to avoid the damage of spinal cord. And there are different dermatome distribution level which can be indicative of surgery and the level of blockade we require. Umbilicus is at T10, Z4 is T6, nipples is T4, and T12, 12, and L1 is at inguinal region, S2, S4 is at perineal region. So these are very important things to memorize and are to keep in the mind to block any area of the body. Procedure is preoperative preparation of the patient, pre-medication with the sedatives, with the midazolam most commonly used, opioids, or nalbuphine is given, and also proton pump inhibitors should be given. Metoclopramide is given to the patient in order to prevent vomiting, and then monitor the blood pressure, vitals, and all the things which we have to take care. We have to look at the hemoglobin, platelets, any pre-op uh, con- condition of the patient. IV line should be managed with the proper preloading, with the fluid should be given with the NPO level, and fluid management. Then we have to give position to the patient. Lateral decubitus position or sitting position in elders. Hip and knee flexed, and neck, shoulder flexed, and knees should nose to knee. There should be flexion happen. And in sitting position, there is saddle block, which is done to block S2 to S4, and hemorrhoids and piles operation on obese patients, pregnant patients. We have to do sitting position, and we have to look at the spinal curvature as well. Then we have to locate the Tuffer's line. Tuffer's line is a line at which L4, L5 vertebrae are present, so we have to locate that. And then we have also a position that is prone position, suitable for hypobaric techniques. Patient should be in prone position and OT table flexed under the flank, just above the iliac crest. So these are some techniques in which we have to perform spinal procedures, and we have to insert the needle. Now as you can see, insertion is introducer in the midline to prevent deflection. Spinal needle, fine gauge needle, is used to decrease incidence of post-dural puncture, headache, or decrease infection, or to avoid skin fragment from entering into the cerebrospinal fluid. A spinal needle is inserted with stillate through the introducer. Needle should be inserted at the midline, directed less than 50-degree longitudinal axis of the vertebral column. Bevel of spinal needle should be kept in the parallel. Loss of resistance should be felt at the lumbar or the ligament of flavum. Now, layers transversed by spinal needle are, as I already mentioned, skin, subcutaneous fat, supraspinous, interspinous, ligamentum flavum, dura, arachnoid, and subdural space. These are the layers which are pierced by the needle. Technique is to remove the stillate to observe the free flow of CSF. Attach 5 ml lock syringe containing anesthetic mixtures of anesthetic agent like bupivacaine, and then stabilize the needle. Attach the syringe and gasping the hub of a spinal needle with the thumb and index finger while popping the remaining fingers against the patient's back. Provide support. That is known as bromage grip. That is known as bromage grip technique. Now inject the agent at the rate of 0.2 ml per second. Aspirate small amount of CSF to look at the free flow and position of the needle, and then remove the spinal needle and introducer quickly and simultaneously in order to prevent damage to the any area. Pyramidal approach is also suitable. 1.5 centimeter lateral to the midline. A spinal needle should be inserted at the angle of 25-degree with the midline without deviation, cephalic or caudate. It is also a good technique. It depends upon the anesthetist to choose any technique suitable and then use the method. Now as you can see here, needle is introduced, and then aspiration of fluid is taken place, insertion and then aspiration, and then we have to look at the free flow of CSF and then injecting the dose of anesthetic agent. Now there are different spinal needles has different parts. One is hub, another is cannula, third one is stillate. Point of cannula is believed to have sharp edges, and then there is certain length of the needles of the spinal. One is Quincke needle, Babcock needle, and Whitaker needle, which has different opening. Next one is Sprotty needle. Quincke, Whitaker, Sprotty needle, and then Pitkin needle is also there. These are different types of the needle, and which are used for spinal anesthesia. Drug is lidocaine or bupivacaine is given. Most commonly we use bupivacaine, which is amide, local anesthetic, sensory and motor split blockage is there. Dose is 7.5 mg, ambulatory surgery. Low concentration is zero point 0.1 to 0.125%, and post-operative analgesia is also there. Drug used in spinal anesthesia, also ropivacaine is used, but we use bupivacaine. There's different dose according to surgery of bupivacaine. As you can see, in perineal surgery there are 4 to 10 mg, 10 mg in saddle block, 10 mg in C sections. We use bupivacaine, that is 0.75%. In lower limb surgery there's 14 to 15 mg, and in hernia we use 15 mg. Or there is an upper abdomen surgery we use 12 to 18 mg, and duration is 90 to 120 minutes for bupivacaine anesthetic agent. Mechanism is sensory nervous transmission is blocked, touch pain receptor are blocked, and autonomic nervous control, which is the heart rate and gut contractility, are also sometimes affected if there is higher spinal chances. And then autonomic sensory fibers are blocked, motor fibers are blocked. Motor blockage causes also sympathetic block, which can cause bradycardia as well. So in this way this agent works. Now sometimes we can give other agents as well, but bupivacaine is given according to the veracity and also according to the patient's age, height, weight, gender, and intra-abdominal pressure, and anatomic configuration of a spinal cord position, as well as we can give site of the injection, direction, factors affecting block, site, direction of injection, direction of bevel, usage of water rate, and rate of injection. Faster rate can cause bradycardia and hypovolemia. Now, characteristic of anesthetic solution is density, amount, concentration, temperature, volume, and vasoconstrictions as well. Factor influencing block height, dose, how much dose is given, site of injection, veracity, and posture of patient. If we give patient the saddle block, it can also block perineal or only perineal area. If we allow the patient to lie down flat, it can cause T10 to lower limb blockage. First of all, sympathetic paralysis, then sensory, then motor blockade happen in different interval of the time. Slow pain, fast pain will be uh, blocked as well. Sympathetic blockage can cause skin temperature sensation, changing in skin temperature, pin prick, sterile needle sensation will be lost, and then indirect effect on respiratory effect is there. High spinal may cause paralysis of intercostal nerves and bronchodilation secondary to hypotension. To reduce pulmonary blood volume, it can cause shortness of breath, GI reflexes, concentrated bowel relaxation due to sympathetic block, absence of vagal block, increased peristalsis, intra-abdominal pressure, bladder urogenital dysfunction can happen if there is blockage. Contra complications can be hypotension, bradycardia, and cardiac arrest due to sympathetic block. High or total spinal block leading to respiratory arrest, urinary retention, and epidural hematoma or bleeding can happen. Late complications are post-dural puncture headache, backache, nausea, focal neurological deficit, bacterial meningitis, or sixth cranial nerve palsy, and urinary retention as well. Treatment: if there is hypotension due to vasodilation, we have to decrease in effective circulation volume. First of all, vasoconstrictors should be given oxygen, raising the leg of the patient to return venous blood into the heart, and then increase the speed of IV infusion. Treat the bradycardia by atropine and adrenaline. Another one is, if there is pregnancy, then aortocaval obstruction can happen due to vena cava compression. Then preload the patient with the fluid, give lateral decubitus patient, vasopressors should be given, and oxygen should be given to the patient until the baby is coming out. How to prevent delayed complication? Use thin spinal needle and sterile precautions should be taken for delayed complication. As we already seen, there is Quincke and pencil needles. These are widely considered. Pencil needles, Whitcare needles, Sprotty needles are widely considered to prevent the post-operative complications. If there is a spinal headache, then remain lying flat on the bed as they relieve the pain. They should be encouraged to drink more water, and if necessary, patient should be given IV fluid to maintain adequate hydration. IV fluid should be given. Treatment of a spinal headache is simple. Analgesics should be given like paracetamol. Caffeine containing drinks should be given to the patient to treat the spinal headache. And then prolong, if there is prolonged headache, then epidural blood patch should be given to the patient. So in this way we can treat this one. So this was some little information about spinal anesthesia, and the next videos we will be looking at the more.